Good evening, everyone. My name is Dr. Ahmed D. Abdulwahab. I am a diagnostic radiologist at the Department of Radiology of the Rizgary Teaching Hospital in Erbil, Iraq. Today, I will present to you a talk about the non-neoplastic bony lesions and the radiological evaluation of non-neoplastic bony lesions. First of all, I would like to give an introduction about the non-neoplastic bone diseases. It is a very big topic with a lot of pathologies to consider, and it cannot be covered in one session or one meeting. And that's why I'm going to talk about few selected pathologies and the importance of how to differentiate them from malignant lesions so that we can better diagnose them, avoid misdiagnoses, and avoid unnecessary biopsies. Some of these pathologies can be presented with focal bone pain and some radiological abnormalities that might mimic benign or malignant bony lesions. In a study done from 1998 to 2005, about the possible diagnosis of non-neoplastic bone lesions, there were either congenital, degenerative, infarcts, osteomyelitis, miscellaneous, and trauma. And if you notice here, the vast majority of the cases were in the form of osteomyelitis and followed by trauma. So these two things are very important for us to focus on and discuss it. Now, first of all, we should consider the normal variants. Normal variants should be considered, especially in children. Most of them are asymptomatic. Some can be symptomatic, and for that, I would refer you to a textbook called Keats, which is the Atlas of Normal Roentgen Variants that may simulate disease. For example, this is the first variant, is the ischiopubic synchondrosis, which is, it can be painful. Usually, it's asymmetrical closure of the ischiopubic synchondrosis, can present with edema and MRI, and can shows active uptake on radionuclide scintigraphy. You can see here on the X-ray, there is some pathology or something here that we might think of as a serious pathology. However, on the MRI also it looks suspicious. You can see here, and also edema on the T2 fat saturated images, and it shows active uptake on the bone scan. So this is just a normal variant, and also it might be painful. Other normal variants that we should keep in mind is the anomalous ossification of the lateral femoral condyle. You can see here there is some lytic abnormality or pathology at the lateral femoral condyle, also can be seen here, and it might be mistaken for other pathologies like chondroblastoma, for example. So we should keep that in mind. Another normal variant that can be bilateral or unilateral is the rhomboid fossa of the medial clavicle. You can see here there is some erosion-like abnormality at the medial end of the right clavicle, and you can see it on the sagittal reconstructed images. And this is the site of the insertion of the costoclavicular ligament. It may be unilateral or bilateral. Regarding the bone dysplasias are non-neoplastic conditions, but they can present with radiologic features simulating neoplastic lesions. First of all, we have to consider the mellirostosis. Mellirostosis is a bone sclerosis that involves a sclerotome, and the sclerotome is defined as the zone of the skeleton supplied by a spinal sensory nerve. Typically, it presents with candle wax cortical thickening of the long bones. The diagnostic confusion arises when the abnormality is in an unusual site or unusual manifestation. You can see here there is it's unusual to have mellirostosis at the iliac bone. You can see the sclerosis and obliteration of the medullary cavity, and it shows active scintigraphy uptake. Also on the plain films, you can see the area of sclerosis with candle wax appearance. Again, melanostosis sometimes can present in the form of intramedullary lesion. You can see it here on the fibula and also on the lateral femoral condyle, and can have present with joint involvement and can present with soft tissue calcification, mineralized soft tissue calcification, and it's just the form of melanostosis. You can see also on the on the axial images, the soft tissue involvement here and here. Now, what about other kind of bone dysplasia is the intramedullary osteosclerosis. Typically presents in adult and in the tibial diaphysis, rarely multifocal. Usually it is unifocal or focal area of involvement, and you can see the cortical and endosteal sclerosis here, simulating possibly a bone tumor or something, or osteomyelitis or other things. And you can see the obliteration of the medullary cavity with active uptake on the bone scan. Another example of intramedullary osteosclerosis, you can see there is the tibia here is sclerosed, the medullary cavity is obliterated, and you can see here on the CT reconstruction images. And also there is some periostitis which should be which might help us to differentiate it from chronic osteomyelitis or osteoma. Regarding the osteomyelitis, which is the most common non-neoplastic condition that affects the bone, according to the study we have demonstrated before, it occurs in the form of two groups, either subacute osteomyelitis, like Brodie's abscess or pyogenic abscess. Also, the other type is the chronic recurrent multifocal osteomyelitis. Okay, it is a non-bacterial osteitis. So let's start with the Brodie's abscess. Brodie's abscess presents in the form of intraosseous abscess in children and young adults. Can be due to Staph aureus or TB, tuberculosis. You can see this is the Brodie's abscess lesion. Typically, it's within 1 to 4 centimeters in size. Most commonly, it's metaphyseal with irregular contour and present with some surrounding medullary sclerosis. On the scintigraphy, it shows active uptake on all phases, so it's triple phase uptake. And on the CT scan, you can obviously see the irregular outline with sclerotic margin and some surrounding medullary sclerosis. Just compare this medullary space to the fibula, the adjacent fibula. On the MRI, the Brodie's abscess will present like any other abscess as a iso-intense on T1 and hyperintense on T2 with surrounding medullary edema, that's almost always, and active periostitis, inflammation of the surrounding periosteum. You can see here and here with the penumbra sign due to the presence of the surrounding edema. We will provide some time to answer the questions at the end of this talk. Okay. Regarding Brodie's abscess, it can be sometimes epiphyseal, and this is where it can simulate chondroblastoma. Like here, for example, you can see it's epiphyseal in nature, also surrounded by edema, and you can appreciate some surrounding sclerosis. This can be mistaken for chondroblastoma, but the clinical history and the lab findings can be of help in this regard. Chronic recurrent multifocal osteomyelitis, it's of unknown etiology. It is considered to represent the pediatric version of the SAPHO. SAPHO, I think you know, it's short for synovitis, acne, pustulosis, hyperostosis, and osteomyelitis. It's a diagnosis of exclusion. Chronic clinical course with relapses and remissions, skin lesions occasionally seen because it's part of acne, and no growth on culture or biopsy material. It is aseptic, non-bacterial. Regarding the chronic recurrent multifocal osteomyelitis, the common sites in the medial clavicle, the metaphysis of long bones, the spine, the pelvis, the tubular bones of the feet. As the name implies, the recurrent and multifocal. It is recurrent, it is multifocal. So we have to do a whole body MRI or scintigraphy to see the lesions and to follow them up whether they improved or new lesions. Name, we need to do a whole body scintigraphy or whole body MRI to look for the lesions first, and second to evaluate the lesion whether they are improved or new lesions appeared. For example, you can see here at the greater trochanter there was a lesion in the old images and it's resolved on the new images, while other lesion appeared on the opposite side, and you can see also other abnormalities appeared at the both femora. So it is recurrent, it is multifocal. Okay. Now, in the clavicle, usually it affects the medial 1 or 2/3 of the clavicle, which present as cortical thickening, expansion, intramedullary lucency. Okay, and typically referred for the radiology as query Ewing sarcoma. It can represent Ewing sarcoma. You can see here as in the form of periosteal reaction, expansile bony lesion. It is painful and it's associated with periosteal, possibly even laminated periosteal reaction and surrounding inflammatory soft tissue mass. All these features can be suspicious for Ewing's sarcoma. In these CT images here, you can see that there is the sclerosis and the site of the osteomyelitis. Also, you can appreciate the periosteal reaction. And on the MRI of the same patient, you can see it's surrounded by an inflammatory soft tissue mass here, and it's surrounded by edema, also on the on the sagittal images, sorry. All of these indicates that this abnormality can be the form of Ewing sarcoma. So sometimes biopsy can be indicated, and if we follow it up, it might heal and the new lesions will appear elsewhere. Also, in the long bones, the chronic recurrent multifocal osteomyelitis can be seen at also in the metaphyseal region, to be specific, in the metaphyseal region, and as you can see, it's present with possibly even moth-eaten bone density with surrounding periosteal reaction and soft tissue inflammation. All of these are suspicious for tumor or malignancy, but the clinical history is of paramount importance here. Now, in the flat bones, results in medullary sclerosis. The chronic recurrent multifocal osteomyelitis in the flat bones can present with medullary sclerosis. As you can see here at the CT scan, there is sclerosis here and sclerosis here, and you can appreciate the multiplicity. Also on the plain phones, you can see these areas of sclerosis. Regarding the SAPHO, as we said a minute ago, it is presented with synovitis, acne, pustulosis, hyperostosis, and osteitis. The radiological part, the part that we are interested in as a radiologist, is the hyperostosis or the osteitis. In the adults, if it's usually it's in pediatric age group. If it presents in the adults, it will involve the anterior chest wall and the spine. And you can see this scintigraphy, the part of the sternum is involved and the adjacent part of the clavicle is involved. Also, you can see it here on the CT scan images. This is the clavicle and it appears hypodense due to the involvement. So, Hyperostosis and osteitis that we talked about, it presents as sclerosis on the plain films or CT scan with bone marrow edema on the MRI. Very obvious, you can see here the sclerosis on the plain films and on the CT scan, and this is a bone scintigraphy, so the left is on the right side and the right is on the left side. It's opposite to what we are used to in radiology, and you can see the increased uptake here, and you can appreciate the abnormality here. Now, the second most common abnormality or pathology to be differentiated from neoplastic lesions is the trauma, especially in stress injuries or stress fractures. Clinically, it's either a fatigue fracture or insufficiency fracture, of course associated with pain during activity. Classical locations is the tibia and the fibula, metatarsals, the femoral shaft, and the pubic rami and sacral ala. These are the classical locations of the stress injury or fractures. For example, you can see here, there is the diagnostic difficulty in this image. It's unusual location of the anterior part of the tibia, and it might mimic an osteoid osteoma. You can see here osteoid osteoma. It's lytic nidus possibly with surrounding sclerosis. So anyone, of course, it's associated with pain, so the possibility of osteoid osteoma should be considered. The sagittal multiplanar reconstruction can help. If you look carefully, you can see the fracture line with the surrounding sclerosis as part of the healing process. Also, the same fracture that we saw in the previous image on the MRI will present as this abnormality involving the anterior surface of the tibia, the hypointense signal, and if you follow it up, it will heal. So the follow-up is important to ensure the healing of the stress fracture. This is an unusual location also in the tibia in the distal part, the distal tibia. This is not a very common location for stress fractures. Also, it appears as a longitudinal fracture rather than transverse. If this was in an adult patient, it will be an insufficiency fracture, possibly due to osteoporosis or osteomalacia. So this here, the edema at the distal tibia, you can see it, indicates an insufficient, here with a clinical history of excessive activity or excessive physical effect, indicating the possibility of stress fracture, not other neoplastic pathologies. If you do a CT scan with multiplanar reconstruction, sagittal and coronal, it will be very informative and very important to us. And you can see here, obviously, the fracture line with surrounding callus formation. Now, regarding the insufficiency fractures, when there is abnormal bone to begin with, there will be hypertrophic non-union of the pubic bone in case of pubic fracture without soft tissue mass. So the absence of soft tissue mass can rule out the possibility of neoplastic abnormality. And when you see it, you look for other pelvic stress fractures because the whole bone is weak, it's abnormal and easily fractured. So you can see here the pubic bone is abnormal with hypertrophic response and non-union. Again, you can see the same abnormality at the sacral ala, the right sacral ala here on the MRI, and on the bone scintigraphy there will be what's called the Honda sign. Cortical desmoid. Cortical desmoid, it's very important to differentiate from possibility of neoplastic lesion. It is an avulsive cortical irregularity. So there is a bony avulsion resulting in focal defect or irregularity, what's called Bufkin lesion. Bufkin lesion. The posterior medial distal femoral metaphysis is the very typical side there. This is the distal femoral metaphysis, the medial metaphysis, the posterior aspect. Here, it is the site of attachment of the medial head of the gastrocnemius muscle. So when this muscle contracts severely or strongly, it will result in an avulsion injury at its site of attachment, and you can see here a bony defect here and here and here that represents the Buffkin lesion. Sometimes subperiosteal hematoma can present be similar to a neoplastic lesion. For example, you can see here, it appears like a soft tissue mass, but with the proper history, with further imaging like this, the CT scan, and you can give contrast and to confirm there is an enhancement or not. Follow it up and it will decrease in size, and later it will heal almost completely. Post-traumatic pseudotumor is a very interesting thing to look for. There is history of an old trauma or fracture that it has been healed. After healing, you can see some lucency at the site of the healing that might simulate a tumor, okay? Just do an MRI, it will be normal, and this will exclude any neoplastic lesion, and you can diagnose it as a post-traumatic pseudotumor. Subarticular cysts are other lesions that are non-neoplastic. Most of them are degenerative in nature. Intraosseous ganglia and geodes are secondary to osteoarthritis. Can be seen less commonly in rheumatoid arthritis and very occasionally in children. Okay, the locations, as the name indicates, subarticular. So it's at the subarticular part of the tibia, which is the medial plateau. The proximal fibula, the acetabulum, the distal femur, and the glenoid. For example, subarticular geodes can be quite large. You can see here, this is a subarticular geode. It's not a tumor, it's not a mass, it is not an abscess, there is no surrounding edema, no bone destruction, no nothing. You have to look for any evidence of communication with the joint space. When you see communication with the joint space, you can have a high confidence in the diagnosis of geodes. Also on the CT scan, you can see these lesions can be multifocal. They have sclerotic margin, and look for the connection with the joint space. Some of them may contain gas. So if you see a gas bubble inside, it helps you in the diagnosis. Some of the geodes can have extraosseous extension into the surrounding soft tissues. You can see here there is some sort of phytic lesion within the head of the fibula. It's well defined, and on the MRI you can see it has a soft tissue extension. Also on these axial images you can see the soft tissue extension, and it shows the rim enhancement on the post-contrast images. Okay? As we said, the importance of the CT scan is to demonstrate the joint communication. You do a CT scan to confirm that this pathology is communicating with the joint space, okay? And at the end of the talk, we will have a discussion panel. So, intraosseous ganglion related to the cruciate ligaments can be either of ACL origin or TCL origin. If they are from ACL origin, you see it at the distal femur, at the site of attachment of the intraosseous ganglion of the ACL to the distal femur. Whilst if you see it in the posterior tibial plateau, they are from PCL origin. As you can see here in the femur, at the site of the attachment of the ACL, there is this intraosseous ganglion, and you can see at the posterior part of the tibial plateau, this is an intraosseous ganglion related to the PCL. Regarding the medullary infarction most of the times are typical in presentation. And I think all of us know what are the typical radiologic features of medullary infarction, but sometimes can present a diagnostic difficulty when it is early or it has a poorly defined marrow edema signal intensity. So you can see this can be destructive as a lesion of the bone, and you might think there's something here, and you can see some edema in the surrounding structures, okay? Again, another example of medullary infarction. It has a diagnostic difficulty Follow it up and you will see the classical appearance over time. Sometimes it can present as cystic lesion. For example, you can see here, this is not very typical of medullary infarction. Cystic lesion is due to osteonecrosis and even might cause some bone expansion. If you look carefully, there is mild bone expansion, and here the diagnosis may require biopsy, especially if the history is not very typical or there's no supporting clues of bony infarction. Some miscellaneous lesions that we should know about, keep it for the last, is, for example, Paget disease. If it is monostotic and unusual age, usually Paget disease in older age group, if it is seen in younger age group, might be a diagnostic difficulty. You can see here the cortical trabeculae are abnormal. They are decreased in number, and the remaining ones are more dense. And on the MRI also you can see the surrounding edema. This is another example of Paget's disease. You can see on the scintigraphy it can shows active uptake, and on the CT scan you'll see the trabecular thickening with loss of the corticomedullary differentiation, as we said a minute ago. If it is multifocal, can be difficult. Usually it is if it's monofocal, can be difficult. Usually it is multifocal in nature. So in conclusion, we should always consider the possibility of non-neoplastic lesions in differential diagnosis of bone tumors. The appearances cannot be typical or atypical. So consider the use of CT for further characterization. My own advice, as I always tell the residents in our department, never see any bony CT scan or MRI without having the X-ray. Always look at the X-ray and then interpret or see the CT or the MRI. X-ray, the plain films, I mean, it is of paramount importance in diagnosing any bony lesion. Thank you very much, and thank you for your attendance.